To understand uterine pathology, we have to look at the organ as an architectural space governed by strict cellular boundaries. The tissue here separates into two distinct functional domains. The inner mucosal lining is the endometrium, which responds to cyclical hormones. The thick outer wall surrounding it is the myometrium, composed entirely of smooth muscle. Almost all uterine morbidity can be traced to a mechanical failure of these spatial boundaries, or a hijacking of the tissue's normal hormonal responsiveness. By mapping exactly where these boundaries fail, we can categorize 8 distinct conditions, ranging from benign localized inflammation to aggressive cellular malignancy. The first category involves in situ inflammation and proliferation, conditions like endometritis, polyps, and hyperplasia that originate and remain entirely within the inner mucosal layer. The second category is ectopic displacement. This is where endometrial tissue violates its borders, aggressively pushing inward to cause adenomyosis, or spilling entirely outside the organ to drive endometriosis. The final category encompasses isolated structural tumors and malignancies, including leiomyomas, leiomyosarcomas, and endometrial carcinoma. Framing these pathologies geographically allows us to stop memorizing lists of clinical symptoms and start treating them as predictable mechanical deductions based on where the tissue goes. Starting at the innermost mucosal layer, a breakdown in the surface environment leads to endometritis, acute or chronic inflammation strictly confined to the endometrium. This is driven by ascending infections like pelvic inflammatory disease, tissue disruption from miscarriage, or foreign bodies like an intrauterine device. Patients immediately present with fever, sharp abdominal pain, and abnormal menstrual cycles. The true danger of this surface inflammation is its upward trajectory. The damage easily spreads to the fallopian tubes, creating heavy scarring that directly drives the severe, long-term complications of clinical infertility and ectopic pregnancies. Resolving this requires immediate removal of the underlying mechanical cause, targeted antibiotics, and often a dilation and curettage procedure. Beyond generalized inflammation, the endometrial surface is also prone to localized overgrowths known as endometrial polyps. Looking at this histological illustration, the architecture of a polyp is highly specific. It consists of dilated endometrial glands supported by a dense fibrotic stroma and embedded with small, thick-walled muscular arteries. Because this specific architecture is entirely benign, these isolated polyps carry zero risk of progressing into endometrial cancer. This stands in strict contrast to endometrial hyperplasia, a generalized pathological thickening of the entire mucosal layer that actively functions as a precursor step to malignancy. Whether creating an inflammatory cascade or forming localized polyps, these specific pathologies share one unifying trait. They strictly respect the deeper boundary of the underlying muscle. When the endometrium violates that boundary and invades into the thick outer muscle, the mechanics fail. We define this inward structural invasion as adenomyosis. As ectopic tissue embeds, the surrounding smooth muscle undergoes compensatory hypertrophy, resulting in a massively enlarged, thickened uterine wall. Histologically, the specific tissue making this inward migration is derived entirely from the stratum basalis, the deepest regenerative layer of the endometrium. Deriving from the basalis, it lacks hormone receptors found in superficial layers. Therefore, this trapped tissue does not undergo cyclical menstrual bleeding. Despite the lack of internal bleeding, patients experience severe menorrhagia and dysmenorrhea. The intense pelvic pain is a direct mechanical consequence of the displaced tissue. The physical presence of endometrial glands embedded inside an enlarged muscle mass forces the myometrium into violent, highly exaggerated contractions. Adenomyosis creates morbidity through internal structural sabotage. Trapped basalis tissue mechanically disrupts the organ's ability to contract normally. Displacement can also move in the opposite direction. When structurally normal endometrial glands and stroma establish themselves entirely outside the uterus, the diagnosis is endometriosis. This outward displacement affects roughly 10% of women during their reproductive years and serves as a massive driver of severe infertility. The primary mechanism driving this ectopic spread is the regurgitation theory. Instead of exiting the body, menstrual fluid flows backward through the fallopian tubes, carrying viable endometrial cells directly into the open peritoneal cavity. Once in the pelvis, these cells implant and form multifocal pathological nodes across the ovaries, the pouch of Douglas, and uterine ligaments. The tissue can even migrate through lymphatic and vascular channels to see distant extrapelvic sites like the lungs. Remaining responsive to hormonal cycles, this tissue bleeds into the surrounding pelvic space, triggering severe pelvic pain, dysmenorrhea, and the formation of distinct masses. On the ovaries, this repetitive localized bleeding forms endometriolas. As the trapped blood ages and oxidizes over time, it creates dark, thick fluid, giving them the clinical name chocolate cysts. Despite its capacity for invasive metastatic-like spread to distant organs, endometriosis is not cancer. Its behavior is aggressive, but its cellular makeup remains entirely benign. Whether pushing deep into the muscle wall or spilling out into the pelvic cavity, ectopic endometrial tissue creates severe pathology strictly through its location. Returning to the structure of the organ itself, we categorize tumors based on the exact layer of origin. Within the myometrium, structural overgrowths of the smooth muscle tissue form benign leiomyomas, while malignant transformations in this same layer present as aggressive leiomyosarcomas. But the vast majority of severe pathology originates back in the mucosal layer as endometrial carcinoma. This is the single most common cancer found anywhere in the female genital tract. This chart details the epidemiological distribution of the disease. It typically presents in patients in their 50s and 60s, splitting into a strict bimodal pattern driven by two entirely different biological pathways. Type 1 cancers are defined by the endometrioid prototype, occurring primarily in perimenopausal women. The physiological driver is a chronic excess of estrogen, forcing prolonged, unchecked endometrial proliferation. Conversely, type 2 cancers are defined by the serous prototype, affecting a noticeably older demographic. They are driven not by hormonal excess, but by underlying endometrial atrophy. Endometrial malignancy requires exact typing. These are two distinct diseases dictated entirely by where a patient sits on their biological timeline. Looking at the entire biological map, the spectrum of disease in the pelvis reveals its underlying logic. Diagnosing uterine morbidity requires tracking the precise spatial boundaries of the tissue and understanding its specific cellular behavior. Whether it is structural invasion triggering violent muscle contractions, regurgitated tissue forming oxidized cysts, or an estrogen imbalance driving cellular proliferation, the macroscopic symptoms patients experience are the strict, predictable downstream effects of microscopic events. By mapping these anatomical deviations, clinical diagnosis moves past memorized symptom lists and becomes an exercise in rigorous biological deduction.